title of our talk today is Everything Old is New Again, the Return of Vaccine-Preventable Diseases. So as people are coming in, I'll just go through a couple housekeeping things. All lines are muted during the program. There will be a question and answer, or there is a question and answer box right at the bottom of your Zoom. Please use that for questions, and we will take a look at those and try to ask those at the end of the talk. This webinar will be recorded and it will be posted to the California Immunization Coalition website. The web address is there, as well as to our YouTube page. This is being brought to you today by the California Immunization Coalition, the American Academy of Pediatrics of California, as well as the Infectious Disease Association of California. So I will be hosting today. I'm Pia Pannaraj. I am a professor of pediatrics at UC San Diego, and my co-host today is Eric Ball. He is a primary care physician at Children's Hospital Orange County Primary Care Network, and we are your current president and vice president of the CIC. So you've probably seen a poll pop up. So please fill out the poll. Our questions are, have you ever seen any of these diseases in your clinic or hospital in your experience? Measles, pertussis, varicella, mumps, or polio? And so that pretty much introduces the topic. All of a sudden, we've had 3 cases of measles in California since December. And all of these are diseases that most of them we thought went away, that we would never have to deal with them again, and they're coming back, partly due to pockets of vaccine hesitancy and low rates of vaccination. So let's see if we can pull up the poll results. Oh, there we go. Okay, so looks like about half and half who have seen some of these diseases, pertussis and chickenpox being the most common. That makes sense, with measles, mumps, and polio a little bit far behind. Okay, great. So that tells me that this is going to be a very important talk, because we're going to go over how to diagnose these diseases. So let me throw this over to Eric to introduce our speakers.
Thank you, Dr. Pannaraj. We have 2 amazing speakers today who are both very involved with the California Immunization Coalition, who are going to speak on these topics and teach us what to look for when these old diseases turn into new diseases and show up in our office. So first, my friend and colleague, Dr. Jasjit Singh, who's a pediatric infectious disease subspecialist here at Children's Hospital of Orange County. She's also the assistant director of the division and serves as the medical epidemiologist for the hospital. She is also the president of the Orange County Immunization Coalition for the last 11 years, and was the most recent president of the California Immunization Coalition, and now serves as our immediate past president. And she is joined today by Dr. Jeffrey Silvers, who is the medical director of pharmacy and therapeutics and infection prevention at Sutter Health. He's also the physician lead in emerging infections at Sutter Healthcare System and leads the antimicrobial stewardship in that healthcare system. He's also on the board of directors of the Infectious Disease Association of California, the advisory board of the California Immunization Coalition, and writes an amazing weekly emerging infections newsletter through Sutter Health. So thank you both for being here today. And with that, I'm going to turn this over to Dr. Singh, who will speak first.
Thank you, Eric and Pia. I know we have so much that we want to cover, so I'm going to just jump right in. As was mentioned, there are now 20 cases of measles across 11 states in the U.S. And the WHO actually just warned us that more than half of countries in the world will face a high risk of a measles outbreak by the end of the year. So I think this webinar is very timely. When I talk about vaccine-preventable diseases, I really like to remind myself of the burden of disease before we had our vaccine. So here you can see for measles, in the early 1960s, there was a lot of disease around. And that, of course, went down very nicely. And in 2000, we had measles elimination declared in the US. Next slide. Since then, you can see here from the CDC data that cases have been on a trend upwards. And in 2019, you can see there were over 1,200 cases in the US. And then, of course, the pandemic happened, and we don't really have our full numbers yet for 2023. Next slide. But of course, there is a lot of measles in the rest of the world. The numbers for 2023 just came out. There were 306,000 cases worldwide. So this is a pre-pandemic slide from the WHO and shows what I think some of us might expect, which is that there's a lot of measles in places like Africa or India, but we may not be as aware of the fact that there's a lot of measles in Europe, particularly Eastern Europe, and that can have an effect on what happens here. Next slide. So what we find in the US is that very often a non-immune person travels internationally and is exposed, brings measles back to the US where it might spread. And so you can see here that we have a significant number of those importations from the European countries because people travel there frequently. Next slide. So when individuals come back who've been exposed, of course, we know that they can spread the illness, and we know that measles is, of course, the most contagious of our vaccine-preventable diseases. So that basic reproduction number for measles, 12 to 16. And you might remember from COVID days that that number represents the number of people that might be infected if you walked into a room with measles. The secondary attack rate is 90%, which is also very, very high. So a very contagious illness. The clinical features that we want to go over are after an incubation period of 10 to 14 days, fever starts off actually relatively low and then increases. That's a good clinical clue because this is not usually an illness where you have an abrupt onset of very high fever. It builds. And then you have the 3 or 4 C's, depending on how you learned them. And what I hear frequently is that, well, I'm not really sure if I'm seeing Koplik spots because I've actually never seen Koplik spots. So on the next slide, this is a great picture from the Red Book Library. I think you can appreciate that they're pretty subtle. So I have seen them a few times, and they look like grains of salt on a red base. And when I've seen them, they have actually been in this location, that inner lower sulcus. And I think the important thing to remember is that this particular enanthem is early and it's subtle. So it is usually there the day before the rash or the exanthem, and maybe that first day of the rash, but then it disappears pretty quickly. So if you are seeing things in the mouth 3-4 days into the rash, those are not Koplik spots. Then we have the exanthem or the rash, which usually starts 2 to 4 days after the prodrome. It is a maculopapular rash that becomes confluent. So that's another good hint that it's measles, because other rashes, say rubella, do not become confluent. Starts on the face and the head, moves downward, fades in that same order. And remember that those kiddos are contagious 4 days before until 4 days after the rash. Next slide. Here's a little conglomeration of pictures. I want to point out that the rash can be a little different, more subtle in darker skinned people, like the little child there in the middle. We really appreciated that during our measles, Disneyland measles outbreak, that it can be a little bit harder to appreciate if you have darker pigmentation. Next slide. So the clinical case definition is fever, rash, and one of the 3 C's. So next slide, you can imagine that during our Disneyland outbreak or when there's heightened awareness of measles in a community, that lots of kids are being sent in for evaluation, possible measles. So this was some data that we put together from the Disneyland outbreak. And we tried to retrospectively look and see which clinical features actually correlated the best with positive testing for measles, which are our cases in red on the right, versus the kids who came in, got tested, and tested negative eventually. And we found that the clinical features of fever for more than a day before the rash began, the rash starting on the face and going downwards, along with respiratory symptoms, were the best predictor of a positive measles test. And we were able to present that data at ID Week that year. Next slide. Of course, there are a lot of other things that can give you fever and rash. Here are just a few examples. Fifth disease. Usually these kids are not very miserable compared to measles kids who really are miserable. And usually we see this in more school-age kids rather than the little tiny ones. Roseola also can give you a fever and a rash. The rash usually appears, though, as the fever is dissipating. Enterovirus certainly can give you fevers and rashes. They can be quite variable. One hint might be that you get lesions on the palms and the soles with hand, foot, mouth disease. And of course, you can have antibiotic reactions, allergies, etc. But honestly, if I were to ask one of my residents, what does this kid have? I have an 11-month-old, high fever, very irritable, red eyes, rash, and cough. What do you think he has? They would all say, on the next slide, you already saw it, Kawasaki disease. And I think this is really important to remember because we have a lot of Kawasaki's disease here in California. It's on everyone's radar. And there is a significant amount of overlap between these two entities. And in fact, during our Disneyland outbreak, the index patient that got sent to CHOC was sent from an outside hospital for evaluation and treatment of Kawasaki's disease, not measles. So I like to remind everybody that if you have a kid that you're thinking sounds like Kawasaki's disease, but they're really wet and drippy, at least consider the possibility of measles. Next slide. So we're particularly going to have a high index of suspicion for measles if our patient is unvaccinated, has traveled internationally, or been exposed to a case. Next slide. And the testing that we want to do is an NP or throat swab, as well as urine for measles PCR, and send that along with measles serology. The other thing that you want to do is phone your friends at your local health department and make sure that they know that you possibly have a case of measles. Next slide. Lots of complications of measles. When we had our outbreak, we saw a lot of diarrhea and croup. In the US, 25% of these cases will be hospitalized, and about 1 in 1,000 will develop encephalitis or die. Next slide. So if you are suspecting measles and seeing that patient for the first time, if you can put them in a negative pressure room, that is ideal. You want to put a mask on them. If you can't, then you want to at least put them in a private room, not have them wait in the waiting area, close the door, and once again, call your local health department. If you get a phone call, things that you can consider that we did was to try to screen those kids outdoors, not have them come into your office. And you can also try to see them at the end of the day. That could be helpful because next slide, you really are trying to avoid exposures. If you do have exposures, post-exposure prophylaxis can be considered. If your patient is able to get MMR vaccine, you want to give that within 3 days of the exposure. If they cannot get vaccine, say it's a pregnant woman, then you might need to consider immunoglobulin, and you need to do that within 6 days of the initial exposure. Next slide. Measles vaccine is very effective, as you can see, and I've listed some of the more common side effects. It is a very safe vaccine. One thing I do want to point out, though, and emphasize is the last bullet point, which is that the vaccine virus cannot be transmitted. We always get a lot of questions about this. Household perhaps has someone with cancer who's on chemotherapy. Parents have been told to be careful about live virus vaccines. But please remember that these vaccine viruses cannot be transmitted. And so you actually want to vaccinate the people in that household and protect that immunocompromised individual. Unfortunately, despite the fact that this is a very, very effective and safe vaccine, the CDC data shows us that national coverage with 2 doses has actually fallen a little bit, as you can see here from the data, and has fallen below 95%, which is what we like to have to ensure good herd immunity. The other disturbing piece about that data is that you can see that there is a little bit of disparity between insured and uninsured individuals. Next slide, please. So, I think that there has been some rhetoric about the fact that the disease is really a benign childhood vaccine, not a big deal, and that the vaccine actually is scary. And I really like this graphic. This is from Caitlin Jetelina, who does a very nice newsletter called Your Local Epidemiologist. So I borrowed this from her. And what she's showing here is, on the left, the effect of measles disease in 10,000 people and the risks that you would encounter versus the risks associated with 10,000 people getting MMR vaccine. And I think you can see pretty clearly that the risk is skewed heavily towards disease. Next slide. I also want to remind everybody that MMR is a travel vaccine, and that if you have a baby between the ages of 6 and 11 months, they should get a dose of MMR prior to international travel. This dose, though, will not count towards their 2-dose series. Kids who are between that age group of 12 months and 4 years, so they've gotten, say, their first dose, you actually do want to give them that second dose if it's been more than 28 days, and that will count towards their 2-dose series. And both of these measures will really help protect those youngest kids. Next slide. And finally, another really good reason to vaccinate. Scientists have really known for decades that having measles seems to suppress the immune system. Michael Mina has done a lot of great work in this area and showed in 2015 that when looking at populations with higher incidence of measles, there were more deaths from other illnesses in the couple of years that followed. And he proposed this immunologic amnesia that happens after measles. And he did a follow-up study in 2019 where he actually looked at antibodies in kids after measles and found that a significant number of their antiviral antibodies disappeared post-measles. And interestingly enough, it did not happen with the vaccine. So another really important thing to keep in mind about the benefits of vaccinating. So going to segue rapidly here to pertussis. Next slide. And start with that curve. Look at that burden of whooping cough in the early part of the 1900s. I mean, it's really very staggering. Next slide. So the way the epidemiology works for pertussis is that immunity wanes, whether you've had disease or vaccine, over time. And so by the time you're, say, an adolescent or young adult, you are susceptible. You can get pertussis and have that sort of very persistent, prolonged cough illness. The more important piece, though, I think, is that you are then a reservoir for transmission to infants. And that infants, when they get pertussis, it can be quite severe, leading to hospitalization and other complications. Next slide. So you may remember that pertussis comes in stages. So the first stage is the catarrhal stage, and that really looks very much like any other nonspecific URI kind of illness. That is followed by the paroxysmal stage, which is what we associate with pertussis, where you have those severe episodes of coughing, cough, 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 cough. You don't breathe between coughs, and then take a big inspiration with a whoop at the end, often associated with post-tussive emesis, very thick, ropey kind of mucus. The convalescent phase is basically very gradual recovery. Next slide. This is a CDC sort of timeline of those stages, and I just want to point out that that paroxysmal stage can last for weeks, and that convalescent stage can last for months. Next slide. Pertussis in the infant, though, can present differently. They almost never whoop, and the babies that we see usually have sort of gagging, gasping, apnea, color changes of the face, and importantly, they usually don't have any fever. So between coughing episodes, they may look okay, but the coughing episodes are very impressive. And if you do get labs on them, they can have very impressive leukocytosis, white counts 40, 60, 80,000 with a right shift, with an absolute lymphocytosis. Next slide. Complication in those babies, 1/3 of infants with pertussis will need to be hospitalized. Apnea is very common, pneumonia in almost 1/4 of them, seizures also not uncommon, and the most dreaded complications, encephalopathy, pulmonary hypertension, leading to a mortality of about 1% in infants. Next slide. So how do we test for pertussis? Well, PCR is usually the way we go. It is actually more sensitive than culture, especially in that first 3 weeks of cough onset. Starts to lose its sensitivity between 3 and 4 weeks. In that time period, up to 8 weeks, you can sometimes get serology to help make the diagnosis, but it's a little bit more tricky. So most often we are making that diagnosis by PCR. Next slide. And treatment, as we all know, is with macrolide therapy, most often with azithromycin. And we want to try to treat early, within 3 weeks of the cough onset. And in our very high-risk patients, those infants under the age of 1 year, up to 6 weeks of cough onset. And remember that treatment may not actually alter the cough part of the illness, unfortunately, but it will hopefully decrease transmission. Next slide. We also need to think about post-exposure antibiotic prophylaxis. So remember that all household contacts, regardless of their immunization status, are going to get prophylaxis, macrolide treatment within 21 days of exposure. And you might also have to think about other high-risk contacts as well. Next slide. A great way to prevent pertussis in infants is actually to vaccinate moms, preferably at 27 to 36 weeks with Tdap. And of course, this is such an effective way because mom makes the antibodies, passes them to the baby, and the baby is protected for the first few months of life. Really, really safe and effective to protect our babies during that highest risk period in the first few months before they can get vaccinated. Next slide. Despite that, though, the CDC tells us that last year, only 55.4% of pregnant women actually got their Tdap, which is disappointing. And on the next slide, you can see that in looking at that data more closely, when you look at successive years, the vaccination rate seems to be decreasing in most categories, and there are disparities between racial and ethnic groups. So clearly, I think we have a lot more work to do in this regard. Next slide. Going to jump to varicella, which is another highly contagious virus. And we get person-to-person transmission, either from direct contact with those lesions or from airborne spread again. The wild-type classic chickenpox, actually, those individuals have 250 to 500 lesions. It's a lot. And you'll remember, of course, that those lesions are in different stages of development. They start as papules, go on to those vesicles, dewdrop on a rose petal, then become more pustular, crust, and then scab. Next slide. Once again, vaccination, so successful, has decreased cases by 97%. But, more importantly, again, decreased hospitalizations by 86% and decreased deaths. So very, very effective. Next slide. So the important part here really is that it's a very effective vaccine against severe disease. Now you can still have what's called breakthrough varicella, which is varicella in people who've been vaccinated, but it is much milder. So they will have 30 skin lesions instead of 300 and much less in the way of systemic symptoms. They are still potentially infectious, but much less so. Next slide. So here are some pictures. The adolescent on the left is a child who had wild-type chickenpox and was unvaccinated, so sort of full-blown chickenpox, if you will. And you can see how different that looks compared to a darker-skinned child with breakthrough varicella and pretty mild disease. So once again, varicella will look different on different skin pigmentations, and importantly, breakthrough varicella can really be tricky to diagnose. This is a nice infographic or poster that we put up in our ER because we've missed a few cases there because it's tricky. It really, it doesn't look like classic chickenpox. And of course, we have a lot of younger providers now who really have never seen chickenpox in their career. So that makes it more challenging for them to diagnose. Complications of varicella. Well, despite the rhetoric out there that these diseases are mild and really are not a big deal, I think most of us who have been in practice for any length of time have seen some severe complications. And chickenpox is interesting in that it has a predilection for superinfection with group A streptococcus. And some of the worst cases of horrific necrotizing fasciitis that I have seen have actually been in post-chickenpox cases. So horrible, horrible complication. Interesting that primary viral pneumonia is not a common complication in children, but one of the more frequent complications in adults, which leads to the perfect segue to my friend Dr. Silver, who is going to talk about some of these diseases in adult patients.
Thank you. I'm going to, I'll have the next slide, please. Okay, so chickenpox in adults. Dr. Singh did a phenomenal job, so I don't want to repeat what she said, but infected adults have more extracutaneous involvement than children in general. The two that are most organ systems that are most important are the lungs and then neurologic complications. The most common reason for adults being admitted to the hospital with acute varicella is actually secondary pneumonia. It can be an acute, actually, varicella pneumonia versus a secondary superinfection. It can be either. Neurologic complication, and by the way, the risk factors for that are smoking, advanced age, COPD, immunosuppression, and pregnancy. Neurologic complications, there's multiple different potential neurologic complications. There are two types of encephalitis. The cerebellar ataxia is more common in children, and that's pretty much the main virus that causes that particular entity. The good news is that it tends to resolve without any residual. Diffuse encephalitis, viral encephalitis in general, is a nasty disease. There's a lot of mortality typically associated with it. In this case, with varicella, it's about 10%, and the residual sequelae are about 15%. So about 25% of people have major changes in their life, including mortality, if they get that complication. Aseptic meningitis is not discernible from other typical viral meningitis with the lymphocytic pleocytosis, the normal glucose, the elevated protein. The transverse myelitis is again not discernible from others, but the hemiplegia and vasculitis are much more distinctive for varicella than they are for other viral entities. Now, in terms of treatment, let's go back one more moment here. In terms of treatment of the encephalitis, acyclovir has been tried. Whether or not it actually alters the natural disease course is really uncertain. Now, part of that may be the older data before we had the multiplex encephalitis meningitis panels, which can diagnose varicella very easily and quickly. In the old days where it would take 3, 4, 5 days to get results back, a lot of times people would delay treatment. And then part of it also may be that acyclovir, which has been around a long time, is not what we would call a stellar antiviral agent, but it has use, but it's not an incredible medication. I'll take the next slide. So shingles, though, is a complication that has not gone away. It can occur in people who've had natural disease, but also occurs after receiving the vaccine. So the natural history of the virus, when you from disease or from the vaccine, is you ultimately get a viremia, and it varies how severe it is. And then the virus settles in the in the posterior ganglionic sensory nerves. And so either the cranial nerves or the spine or the autonomic nerves. And it becomes quiescent there. And then it can come back at some stage in life, usually as people get older or as they get more immunosuppressed, but sometimes it occurs in other situations. It's not just the rash. It's really the pain associated with the rash that is so impressive and difficult to treat for years. It can be life-changing for people, and it can recur. You also notice quickly here that you have the first branch of the trigeminal nerve on the right upper picture there of the woman. You can see how it just goes right down the midline because it's only been in the right trigeminal sensory ganglion, and it's not on the left side. And that's just the way the virus works. And you'll see on the left side, it's at C3-4 at the shoulder. And again, this is vaccine preventable. If I could have the next slide. The Shingrix vaccine, what a great vaccine this is compared to the previous vaccine. So previously, let's say about 7 years ago, we had this Ostrix vaccine, which was a live chickenpox vaccine. And it was composed of 14 times the concentration of the usual chickenpox vaccine that we give to kids. So it was a high concentration. And of course, you could not give it to immunosuppressed patients because of the high viral concentration in there. And unfortunately, as people were older, it didn't work very well. And after people got it, the immunity waned. So now the Shingrix has come out as an adjuvanted recombinant vaccine. And it works at all ages, and because it's not live virus, it also works for immunosuppressed people. So 50 years or older, there were 2 different trials, about almost 28,000 participants. They separated the 2 age groups, so 50 and older and 70 and older. And look at this, 97% vaccine efficacy at 50 to 69 years old, 91% at over 70 years old. Excellent. Now, this is short-term efficacy, but in this case, as they're collecting data, it looks like the protective effect is continuing and continuing and continuing. It's anticipated to last 9 years or more. Very exciting. And then the other thing is people who are immunosuppressed, which obviously could never have gotten a live vaccine, 68% vaccine efficacy 2 months after a stem cell transplant. That's the most difficult population of all to get a vaccine response out of. So that's wonderful. 87% after people being treated for things like acute leukemia. So on the left, no maximum age because it works at all ages. Even if you have a history of prior shingles, you get it because shingles can recur and the pain can recur, and that can assist with mitigating that. Even if they previously received the Zostavax because it stopped working, and even if they received the varicella vaccine for chickenpox, it's a win-win. Win-win. Next slide, please. Let's move over to polio here. So eradication is still possible. Now, polio is very different than smallpox. And even, we've talked about previous infectious diseases Dr. Singh talked about. Historically, polio affects mostly young children. Although most cases are asymptomatic in polio, like 70%, and 25% have a nonspecific, viral syndrome with fevers and headaches and myalgias. 5% get neurologic stuff, but only about 0.5% develop paralysis. So it's about 1 in 200. So 95% of people are not recognized as having polio. So the good news and bad news about polio. The good news is that most infections don't cause neurologic problems. The bad news is if you want to get rid of the disease, and since so many people are asymptomatic when they carry the virus, ongoing transmission cannot be stopped without worldwide immunizations. So here we are. Here's our world situation. And the vaccine the inactive vaccine was first approved in 1955. So 1952, before the vaccine, there were almost 58,000 cases identified in the United States, and that doesn't count asymptomatic people. In 1979, there estimated about 1/3 and in 1988, the World Health Organization said this has got to stop. So since 2000, they've given more than 10 billion doses of oral polio vaccine to nearly 3 billion children. Incredible. And here we are last year, only Afghanistan and Pakistan continue to have endemic wild type polio. There's 3 types, 1, 2, and 3, and 2 and 3 have been eliminated. And 1 is still existing in Afghanistan and Pakistan. I put a blue arrow where it was in Afghanistan and some red arrows where they were in Pakistan. But that doesn't stop polio because most infections now are from vaccine-derived strains, and there's multiple countries I'll show in the next slide. So this slide from the CDC Travelers Health site shows Africa there where there's polio detected within the last year in almost all of Africa. On the right in Asia, not the far right, but it shows Pakistan and Afghanistan where there's wild type, and then the far right is Indonesia. So there's a lot of vaccine-derived disease in the world still, and that's our main challenge. Let's move on to the next slide. So what about the disease? Okay, so why can we eradicate smallpox and not polio? So when a person has smallpox, they almost always get symptomatic. There's very few asymptomatic people. So what you do is kind of the dual ring of immunization like we did with Ebola. And you immunize everybody who's been exposed to that person, and you immunize a second ring of everybody who's been exposed to the ring of people that have been exposed. And that's different than polio because polio, 70% asymptomatic, another 25% you don't recognize, you can't do contact tracing. So in terms of the virus, I guess I mentioned there's only 1 type left. That's what we have is wild polio type 1 and the vaccine-derived strain. Okay, let's move on to the next slide. So why do we have circulating vaccine-derived polio virus? So in countries that are resource challenged, the oral polio vaccine has been utilized because it's convenient, it's cost effective, and it is easy to store and resource. Okay? So it's been given to a lot of people. That's a live attenuated virus. It's administered to a person who's unvaccinated or undervaccinated. It's given the virus, then of course, that's the drops on the sugar tube, like some of us took when we were kids. And it stays in the respiratory tract for up to 2 weeks in the upper respiratory secretions, in the GI tract for up to 2 months. During that time, while the body is developing immunity, it is multiplying. And the mutations that were introduced into this vaccine to attenuate the virus are not helpful to the virus. Viruses are all about propagation. How can I survive? How can I multiply? How can I spread? And if a mutation lessens its fitness, then the natural trend is for the mutation to be reversed. So it's mutating as immunity is being developed, and then it passes out into the stool and then if you're in a population of people that are unvaccinated or undervaccinated, that means incompletely vaccinated, then they may acquire that virus. the virus again continues to mutate, and ultimately it may develop its pathogenicity again, which you can see on the third one from the left. Virus develops pathogenicity, it's neuropathogenicity. That's actually only one mutation. Now, I personally don't have a postulate as to why that is helps viral fitness. Because paralyzing a person doesn't help transmission. But anyway, it does happen. And then an unvaccinated or undervaccinated person who then gets that strain in it, which has the neuropathogenicity again, they develop polio. And you got ongoing transmission. If I could have the next slide. So I mentioned the non-paralytic presentations already. The incubation period is short. For non-paralytic disease with the little, prodrome syndrome. The paralytic disease is 1 to 3 weeks. And again, most people are asymptomatic. Now, and again, the non-paralytic, somebody's going to come in and they got a headache and they got a fever and a sore throat and their muscles hurt. And that's like, okay, I see that all the time. But what is distinctive is it can last for a few weeks. So that will lead to more of a workup. And you'll probably look for Epstein-Barr and CMV and a few other things. But by the way, you need to ask them, have you been anywhere where where the country has polio? Or have you been near anybody who's traveled to those countries, be it Africa, right? Indonesia, and Afghanistan, Pakistan, your list has changed, but it's pretty impressive. Remember, most people who get it are asymptomatic, so they could easily give it to somebody else who's unvaccinated. They can come to you with polio. More concerning clues will be anxious, restless, apprehensive, nuchal rigidity, things that suggest that you have meningitis in there or early encephalitis. Okay, neurologic presentation for the anterior horn. So this is important. So what we mentioned for chickenpox is it goes to the posterior sensory ganglia, and polio goes to the anterior horn. So shingles, of course, has sensory changes and pain, and polio has motor neuron. So what they present with is that severe muscle pain and spasms, followed by asymmetric weakness that progressively worsens over a few days. Asymmetry is really an important clue when you think of things like Guillain-Barré syndrome or botulism, when you see the things like that, or the tick paralysis. I've seen all those things. They're more symmetric than polio. And of course, they typically don't have fever where polio can. The disease progression stops when they've been afebrile for 48 hours. And if they start with it's a flaccid paralysis, lower motor neuron, but they start with brisk reflexes and become absent quickly, as you'd expect with lower motor neuron disease and course fasciculations. They may get phantom pains with paresthesia complaints like we see with spinal cord injury sometimes, but if you do sensory testing, you will not find anything. Next slide, please. So just as a partial differential of acute flaccid paralysis, I mentioned some of the things like botulism, Guillain-Barré syndrome. I think it's important to talk about acute flaccid myelitis because we do see cases, those mostly in kids though, but sometimes adults. It's due to enterovirus G68, maybe sometimes A72, and it comes around every few years. West Nile virus, which of course goes all across the country. Only a small amount of disease is neuroinvasive. Most of it's just meningitis, but they can have acute flaccid paralysis. Next slide. So let's move quickly over to mumps, and it's the only cause of epidemic parotitis. Now, there's multiple other viruses that cause parotitis, but those are isolated cases. They're not going to be an outbreak. Incubation period, couple weeks. Contagion, respiratory droplet secretions, the same stuff that we've heard about for chickenpox and for measles, but it's not as contagious. It is contagious, but it's not as contagious as, definitely not measles, and not as contagious as chickenpox. And what we have found pre-vaccination data show that kids who got it were a little bit older, 5, 6, 7, 8, when they got mumps compared to measles and chickenpox, were in the first couple of years typically. The vaccine shifted the average age of infected persons. It's mostly older teenagers and young adults now. If I can have the next slide, please. So like the others, there's an asymptomatic group which enables the virus to propagate and spread. It's about 20% with mumps compared to 70% with polio. There's a pre-symptomatic period, which is that same viral syndrome I talked about. And they come to your office and yeah, you've got a virus. And then they get viremia. And from there, when they get the fevers and sick, then it disseminates to the glands, including the parotid. It can go to the pancreas, goes to the submandibular gland, and then gets to the CNS. So what about the disease? How severe is this? So we talk about measles and the high rate of hospitalizations. Mumps, not typically more severe in high-risk groups. We talk about chickenpox pneumonia in immunocompromised people. Hospitalization for mumps is uncommon. Death is rare. So why do we care? Okay, well, it really is the orchitis, and the ophthalitis is a small part of it, and then neurologic involvement. So orchitis, 15 to 30% of unvaccinated post-pubertal males with infection will get orchitis. Now, it's important when you have a patient, you wonder if they have orchitis in terms of you evaluate them as part of your examination. So orchitis is actually involvement of the testicle. The scrotum will be red and thickened. The testicle will be tender. And then you feel for the epididymis because in most young adults in this age group, let's say 18 to 25, that are higher risk for getting this disease from breakthrough infections and outbreaks, the epididymis is usually a bacterial infection to get epididymitis, and the testes feel normal. If the epididymis is normal and the testes is tender, then you, of course, always have to do ultrasound and wonder whether or not they could have torsion of the testes. Now, presuming this is mumps, which you would have to make the diagnosis to know for sure, unless they have parotitis with it, testicular atrophy develops in 30 to 50% of unvaccinated males. That's a lot. Now, it's usually unilateral, but it can be bilateral. It doesn't always lead to infertility, but it can. And I know we have IVF to help, but no one wants to have to deal with that. Vaccination absolutely decreases the risk and severity, 66% after one dose, by 74% after 2 doses. That's a huge deal. The ophthalitis in females, it's about 5%, again, unvaccinated only. It's less common if they've been vaccinated. Fever, abdominal pain, emesis. Okay, if it's on the right side, you're going to think about ovarian torsion. You're going to think about a TOA. If it's on the left, if it's on the left side, you're going to think about that. If it's on the right side, you're going to add the appendicitis to that. And don't know what it does for fertility. Next slide is the CNS disease, aseptic meningitis, which is like all the others, and people do fine. Encephalitis, though, again, morbidity and mortality, and it's a big deal. But before vaccine, what they saw a lot in kids was sensory neural hearing loss, and that's a big deal. That's we don't have anything to do about that. Guillain-Barré, as we see, like with Zika and with chickenpox and other diseases, that happens, as well as transverse myelitis. And the facial palsy you expect because the parotid is swollen, the facial nerve goes through it and gets ischemic. Next slide. There's a partial differential diagnosis, and you can see of the viral etiologies here. And I've seen parotitis actually with all of those through my years. Mumps is the only one that the outbreaks occur in clusters. And next slide here. Now, we've had various outbreaks. So what's notable about mumps? So 20% are asymptomatic, 20% have a nonspecific viral syndrome. And then, so at least 60% are symptomatic, but how much the parotid swells varies. And people, when they look at these high vaccinated college populations, where they actually had an outbreak. So it was due to waning immunity. It's also due to, which that happens with mumps, vaccine more than some other vaccines. And then the 2 doses are 88% effective. So again, it's not perfect. So you start to see some outbreaks in people who are going into military recruit camps and colleges and stuff. And only 1 out of 7 people in highly vaccinated college population can say, oh yeah, I got it from so-and-so. But they don't know the other cases because, again, asymptomatic or a non-specific viral syndrome. Next slide. So what about the MMR? So I told you it's about 88%. Outbreaks will occur. why not give everybody a third dose? Well, the only time they recommend a third dose is if you're part of a group of population at risk and there is an outbreak ongoing. We do know that the mumps vaccination lowers the risk of infection and the severity, including orchitis and hearing loss. Next slide. So what are some of the take-home messages? Next slide. Propagation of the virus is the name of their game. The goal of a virus is to multiply and spread. It's, hurting a person, causing someone to die, that's like a sideshow for a virus, because that doesn't help the spread of the disease. Maybe a little in Ebola, but most other diseases, it doesn't help the virus. So getting them sick where they're really contagious, that helps the virus spread. Some, things that we'll see maybe like COVID and cause a pandemic, but others that we've been talking about today may just reemerge, staying under our radar. Need to be prepared to recognize that what is old is new again, and that the vaccines work. Thank you.
That was fantastic. Thank you both for excellent presentation. We have about 5 minutes for questions. So I'm going to start by asking Dr. Singh, I have 2 quick questions for you about measles. So first off, is there any treatment for measles? And then secondly, I had some questions from some of my colleagues. If you could run through really quickly again, if you have a suspected child with measles in your office or adult with measles in your office, you call the health department, but then what do you do?
Yes, this has been coming up frequently, right, Eric? So to the first point about treatment, there's no good antiviral treatment for measles, but we do give vitamin A as part of our treatment to kids. And sometimes they need some fluids and other supportive care. As far as managing that suspect measles case, as I mentioned, if you get a phone call in advance and you can screen them outside or at the end of the day, it would be ideal. If they do enter your office, you don't want them sitting in your waiting room. You want to get a mask on them as soon as possible, get them into a room, close the door, and any provider that goes in should be masked as well, preferably with an N95. If you have any way of having negative pressure, HEPA filter or a negative pressure room, that is ideal. And phone your friend at the health department.
And so testing, you mentioned serology as well as NP swab or oropharyngeal swab.
Yes.
I assume you don't send them to Quest Diagnostics to get their blood drawn. So who does the serologies? And most of us don't do blood draws in our offices.
So serologies actually are done by many commercial labs, but I think the more important part of it is the PCR testing. And here in Orange County, that's done by our local health department lab. And it's really great because they will get those results to us in a really timely fashion. And we do want both an airway swab as well as urine for PCR.
So if I could make a quick comment of what we've also noticed at Sutter Health is sometimes adult doctors have been ordering the IgM antibody alone, and there's false positive IgMs. They don't even order the IgG with it, and they don't. You really have to do the PCR test. And I agree with Dr. Singh. We have to use our health department. We should use our health department, and we should let them know as soon as possible. But do not order the IgM alone for diagnosis.
Thank you. Dr. Silvers, I have a question for you from the audience. How do you advise families who express concern that the majority of current polio infections are from vaccine strains rather than the wild? This attendee had a patient who refused the vaccine for this reason.
Well, we're not giving the live polio vaccine here. We're using the inactive polio vaccine, and it doesn't cause disease. And so in the United States, it's not an issue. In terms of the live polio vaccine in other countries, there's a couple of things that are happening. Number one is they've been modifying the vaccine to lower that risk dramatically. So the vaccine for type 2 is a new one already that doesn't have the same risk of mutating back to the wild type. And UCSF just reported that they have developed a type 1 and a type 3 also. So we're probably not far away from having all three as a new type of vaccine that has a much lower risk of reverting back. And the other thing is the risk is zero if everybody's vaccinated. You aren't going to get disease if you've been vaccinated.
Excellent. We have time for one more question. So this is for both of you. A super common question that we get in pediatrics is when a family has a baby under 12 months who has not had a varicella vaccine, but they are in contact or there is someone in the family who has shingles, a grandparent or what have you. So what is the contagiousness of shingles to an unvaccinated infant? How long does that baby need to stay away from that grandparent? Does the baby have to stay away from the grandparent? What do you advise?
Well, why don't I start with the contagion of the adult, and Dr. Singh can talk about the baby. So the contagion of the adult depends on the stage of the infection. So once it's scabbed over, it's not contagious. So that's one. Number two is it can be covered because the shingles is a reactivation of a quiescent posterior horn ganglion, and it's not in the respiratory tree. So it's different than chickenpox, which is also in the respiratory tree. So all contagion is from the skin lesions. If the skin lesion, if they have a lumbar L4 shingles outbreak, they're not contagious if their skin's covered. If they have the facial lesions like I was showing you, then they are contagious, and they should definitely stay away until it's all crusted.
Yes, I completely agree with that. Most of the time it can be covered, so there's very little risk. And for those young babies, infants, remember that hopefully mom has either had chickenpox or been vaccinated. And so baby should have some antibodies from mom. So that provides some protection as well. And usually chickenpox in that age group is fairly mild.
Excellent. Thank you both so much. Dr. Singh, Dr. Silvers, this was fantastic. And I think we all learned some pearls so that if any of these patients come through our doors, we will be able to identify them. I wanted to thank the over 300 people who attended this webinar. You're all fantastic. And thank you for all you do and for protecting California. And before we end, I want to talk about an important event that we put on every year through the California Immunization Coalition, called our annual summit. So this year our summit will be in Sacramento on June 5th to 6th. If you enjoy talks such as this and learning from experts such as Dr. Singh and Dr. Silvers, this is an incredible conference, very multidisciplinary, a lot of great speakers, and I hope you could attend. We have early registration, which is still active. And if you want to present, we are still accepting abstracts at our annual summit. Again, June 5th and 6th in Sacramento. You can register at the link above, and we'll also have it on our website at immunizeca.org. So we hope to see you there. You will receive an evaluation at the end of this webinar. Please fill it out. It helps us to pick topics for the future and also to make these webinars better moving forward. And again, thanks to Cameron and Catherine from the California Immunization Coalition, who are fantastic and put this together, as well as our partnership with the Infectious Disease Association of California, American Academy of Pediatrics of California. And we will be back in the future when things pop up. We will be here to talk about them. So thanks so much. Again, you can find all of our previous talks on our website at immunizeca.org or on our YouTube channel. So if you have friends who could not attend this, please let them know they can see a recording of this as soon as we're done. So thanks all. Thanks, Dr. Singh. Thanks, Dr. Silvers, and we'll see you next time.
Thank you, everybody.
Thank you.
Good afternoon.